talk. The first two talks, I think, when Dr. Tinku is here, we can start off with them. We'll start off with one very common conditions, very often seen in our practices, Serpiginous choroiditis. And it's a very great mimicker of many more conditions, very easily misdiagnosed and mistreated. And I request Dr. Garima to shed more light on Serpiginous.
Thank you. So as Dr. Ritesh has already told, let's know about another entity of posterior uveitis, a creeping cause of vision loss, that is serpiginous choroiditis. We'll be covering the topic under these headings as quick as possible. Though initially it was diagnosed in patients with tuberculosis and syphilis, for the first time described by Jonathan Hutchinson in 1900, it was predominantly considered as autoimmune process. The wavy pattern of lesions led to its term serpiginous, coined by Gauss. In India, the reported prevalence varies from 1.2 to 5% and makes 0.2 to 5% of total uveitis patients. By definition, serpiginous choroiditis is a recurrent, asymmetrically bilateral inflammation of choroid affecting outer retina. The patient presents with floaters or metamorphopsia or paracentral scotoma, but central vision might remain intact till macula gets involved. Anterior segment may or may not show severe reaction, and fundus shows ill-defined grayish or creamy yellow-colored patches lying at the level of deep retina or RP, which progress in serpentine fashion to coalesce. Other features best confirmed on OCT are edematous retina, atrophy or loss of overlying retinal pigment epithelium, and adhesion of outer retina with underlying inflamed choroid. The inflamed choroid shows hyperreflectivity on OCT, which is seen as waterfall effect. Serous retinal detachments can also be seen in severe active cases. Fundus Autofluorescence is a non-invasive tool for assessment and close monitoring of disease activity. Active inflammation may show hypoautofluorescent halo that surrounds the edges of hyperfluorescent lesion over here. It probably signifies the edematous retina. Then gradually, hyperautofluorescent sharp border develops around lesions. They show a transition zone of inactivity. Lesions start healing by 6 to 8 weeks with or without treatment and show varying stages of resolution. It is seen as diffuse RP mottling with extensive atrophy of RP and choriocapillaris. These are characterized by total hypoautofluorescent areas with sharp borders, indicating the complete loss of fluorophores. Recurrences are common and usually occur at the edge of previously healed lesions within months or years. Because of variation in clinical presentation, the disease has been described by various other names, but it is important that we know about a few important terminologies and classification. So to begin with, serpiginous choroiditis is classified in two main types, classic serpiginous and serpiginous-like or multifocal serpiginoid choroiditis. This is really important to avoid confusion between multiple examinations by single or multiple examiners over a long period of time. Mere terminology gives a big clue about etiology here. So the treatment is directed towards the specific etiology, thus minimizing the side effects. Then serpiginous is, classic serpiginous is again classified in two broad types depending upon location of lesions, peripapillary and macular. Though the names are autosuggestive, but we must know that peripapillary classic serpiginous is most common type. The lesions are usually unifocal, occurring around the optic disc, then progress in serpentine fashion to involve macula. Macular CSC, on the other hand, though it's uncommon, but it's a dreaded cause of vision loss because the lesions are close to the macula or fovea to begin with. And again, it has higher risk of development of CNVM2. Now we come to the infective cause, that is multifocal serpiginoid or serpiginous-like choroiditis. These patients are relatively younger, come from tuberculosis endemic areas, and in these eyes we see unilateral multifocal choroidal lesions of varying sizes and shapes, sparing juxtapapillary lesion. Here it is important to look for inflammatory reaction in vitreous, because not only the location of lesions, but higher inflammatory reaction in vitreous differentiates it from the autoimmune variety. And also, these lesions show progression and development of new lesions even despite effective corticosteroids therapy. If we talk about etiopathogenesis, in classic Serpiginous, there is an underlying organ-specific autoimmunity, but the specific trigger for this localized ocular immune response remains unclear. In multifocal or infective variety, though most of the cases are associated with tuberculosis. But isolation of bacilli from these patients is a major challenge. And then second in line is syphilis, and then varicella zoster and herpes simplex virus. They have also been found to be causative factors. But antiviral therapy has not been effective, neither in healing nor in preventing recurrences. OCT, fluorescein angiography, and autofluorescence, these are major diagnostic tools besides lab investigations to rule out infective cause. Now, positive MON2 or QTB gold along with positive findings on chest X-ray or CECT, these are considered sufficient enough to label it as presumed tuberculosis, even if evidence of mycobacterium in ocular fluids is not available. Fluorescein angiography in early phase show hypofluorescence due to hypoperfusion of choriocapillaris and inflamed retina. Gradually, there is leakage from the choriocapillaries at the borders, so it gives hyperfluorescent borders. And later on, due to profuse leakage from larger choroidal vessels, it gives hyperfluorescence. ICG is not much helpful in active lesions as it gives hypofluorescence throughout all phases due to blockage effect, but its advantage lies in delineating the disease and knowing the extent of choroidal inflammation. And more important is to diagnose CNVM within the lesions because these lesions show hyperfluorescence. The treatment options include steroids alone or in combination with immunosuppressants for classic serpiginous. In multifocal serpiginoid, the treatment is targeted towards the specific etiological agent. See, this is very easy to say and listen, but it is important that treatment is always be started under guidance of a physician or rheumatologist and with close monitoring under a multi-specialty team because non-judicial treatment has not only led to systemic complications but even deaths have been reported. So, proper diagnosis and treatment under multi-specialty teamwork, it is the key to deal with this creepy cause of vision loss. Thank you.
Thank you, Dr. Garima. Are there any questions? Dr. Garima, if you have a serpiginous choroiditis, not an infective one that you're dealing with, and it's threatening fovea, do you change your management strategy there?
Yeah. See, initially, if fovea is not threatened, we ask the patient to get the investigations first to rule out the infective etiology or something. But if fovea is threatened, we straight away start with steroids. We straight away start with immunosuppressants, but steroids are usually preferred. So even if IV steroids are needed, we have to give IV steroids.
Yeah, so you prefer IV in fovea threatening situations or orals?
I prefer IV.
Dr. Anja, anything different in Singapore? Do you use IVMP that much?
I think in Singapore, without investigations for ruling out infections, the steroids are not started. You can really get that done within 24 hours, so it's not a problem. But yeah, it's okay for us to say that in a forum, but managing the patient with fovea involvement or threatening fovea, sometimes even with instituting treatment, the fovea may get involved.
Yeah.
So in that sense, it's the same management. And patients are again quickly in combination with other immunosuppressants as well. So we know of either to ESA or to MM.
Dr. Neha, anything?
I think also because as she mentioned here in India, most commonly it's secondary to tuberculosis. So even if we do start steroids before starting any anti-infective therapy, it doesn't really worsen the condition in our case. Of course, if it's an atypical presentation or the area is such, then we might wait for the investigations. But more usually than not, we are dealing with the tubercular pathology. So we can start the treatment straight away while we are waiting for the investigations as well.
All of them are treated also with antitoxin.
That is a big gray area. So what we follow is, recurrences definitely we do treat. even if the results come out to be equivocal. And if the tests for latent tuberculosis are positive, then more often than not, we do give anti-tubercular therapy.
So that probably addresses your first question about whether can start steroids or not, because one of the other things is syphilis. And even if you were to treat with steroids for a couple of days, it's not going to make that much of a difference if it was because of syphilis, so it should be okay.
So we see tuberculosis more commonly, and in any case, we prefer to start steroids before the ATT to prevent paradoxical reactions in such cases.
Thank you so much. Moving ahead, we'll go ahead with the next talk with Dr. Neha. Dr. Neha is going to talk about another very common entity which we see in our practices, Toxoplasma. We have been reading about it since quite some time and very often see it in our clinics also.